Today we're very happy to interview Professor Susan Mandel. Professor Susan Mandel is, I would say, a guru in thyroid and thyroid ultrasound and management of thyroid nodules. I'm Dr. Alaaeldin Bashier, and I'm a consultant endocrinologist at Dubai Hospital. I'd like Dr. Susan to introduce herself today.
Yes, thank you. First of all, it's a pleasure to be here, and it's a pleasure to be here with you. So my name is Susan Mandel, and I am a professor of medicine at the Perelman School of Medicine in the University of Pennsylvania and the division chief there for the endocrine division. And I've been doing ultrasound now for over 30 years, which makes me sound old.
Oh. These are really great, and it shows in your experience. But you started almost 30 years, would say probably 1990s, you started doing the ultrasound. Now, out of your experience, how frequent do you see thyroid nodules, and what do you think the general overall prevalence of thyroid nodules?
Yeah, so thyroid nodules are really common, and it fortunately, most of them we can probably clinically leave alone. So if you look at studies where they've actually used ultrasound, which is the most sensitive way of finding thyroid nodules, I always say to patients the likelihood of having a thyroid nodule if you were to have an ultrasound is kind of equal to your age. So if you're a 50-year-old person, there's probably a 50% chance that we'll find something on ultrasound. Unfortunately, the vast majority of those we don't need to do anything about. If you're trying to feel someone's thyroid, you probably only feel thyroid nodules in maybe 5% of patients as they get older, because most of these nodules are just so small and are not easy to feel.
That's interesting way to remember it. So 50%,
Yeah.
70, it goes to 70%. Do you think now even the prevalence is increasing because of the excessive use of thyroid ultrasound even before starting GLP-1?
Yes, so there have been a number of studies that looked at, actually some of the best studies I think have looked at large insurance databases and have shown that as you see coding for any type of neck imaging, it doesn't just have to be ultrasound. As you see an increased use of coding for neck imaging, you see an increased use of the diagnostic code for thyroid nodules, so that our ability to diagnose thyroid nodules really almost relies on radiology. I say that when I see patients, even with large nodules for biopsy, 70% of the people I see, their nodule was not detected by somebody feeling their thyroid, but because they had a neck CT, because they had neck pain, or even a chest CT that goes as high as the neck, and so you find it on the imaging.
So that means the detection of thyroid nodules is currently only small nodules, not the larger ones, right?
So no, we find both, and if you look at data looking at the prevalence, for example, of nodules and even thyroid cancer, although the incidence of small thyroid cancers is increasing faster than that of large cancers because we're finding smaller nodules, even the incidence of larger thyroid cancers is increasing. So whether it's something environmental, whether it's related to an environmental toxicant, whether it's related to radiation exposure, there's many, many theories about that.
So you mentioned earlier that many of the thyroid nodules doesn't need to be touched. So what are the clinical and ultrasound features that makes you suspicious of thyroid nodules?
Yeah, so as clinicians, we always start with a history. So there are certain patients where there are key attributes in their history that we know increases their likelihood of thyroid cancer. So there are some genetic syndromes, for example, for medullary cancer, the RET oncogene, but even something like the P10 hamartoma syndrome, those patients have a higher risk of follicular carcinoma. For papillary cancer, we don't have a gene for genetic papillary cancer, but generally if 3 or more family members have papillary carcinoma, we get concerned. I think the most important thing for us to recognize in history is the history of external beam radiation exposure to the head and neck area in someone below the age of 20 to 25. Okay. So older patients, someone who had Hodgkin's when they were 34 may become hypothyroid, but when the thyroid is exposed to radiation at a younger age, that actually leads to tumorigenesis. Okay. And so individuals who are adult survivors of childhood malignancy, whether the radiation was head or neck or whether it was even total body irradiation for a bone marrow transplant, those individuals need lifelong surveillance. So those are the history features. Clinically, obviously, if someone presents with large lymph nodes on one side of their neck and has a nodule on that side, there are many reasons for large lymph nodes, but we do get concerned when we evaluate the nodule, especially if it's suspicious, could that be metastatic papillary cancer? But certainly, recurrent laryngeal nerve palsy, a rapidly growing tumor, can do that. But the one thing I always like to assure patients of is sudden growth. So obviously, anaplastic cancer and lymphoma will grow suddenly. They are very rare. The most common reason for the sudden appearance of a thyroid nodule is hemorrhage into a nodule, and that can happen to a benign or a malignant nodule. So it's really good to be able to calm someone down who says, this suddenly appeared over the last 2 to 3 weeks and it's a nodule, and you do an ultrasound and you see it's hemorrhage. You still have to evaluate it, but it doesn't change the risk of cancer. So those are basically the clinical history and physical exam findings.
And ultrasound features?
Yeah, so and one other thing on physical exam, which is not very common, but if someone swallows and the nodule is fixed, we get worried about invasive cancer. So whenever we find a nodule on CAT scan, MRI, physical exam, the first thing we say is we need to do an ultrasound, because the ultrasound imaging characteristics of a nodule are what allows us to risk stratify a nodule and basically say, as I said to you in the beginning, a lot of nodules we don't have to worry about. So starting about 30 years ago in Europe, the first publications came out looking at different ultrasound features, the consistency, solid or cystic, the echogenicity, how bright the nodule is, the margins, are they sort of infiltrative or smooth, whether it has bright echogenic foci in it, and its shape. And those 5 categories have become the foundation for all of the ultrasound risk stratification systems that we use that allow us to take a picture of a nodule and then talk about it as it's being very low risk, low, intermediate, or high risk for cancer.
Excellent. There was one feature. Initially, people were suggesting that the vascularity, when there is a high grade of vascularity 3 and 4, it increases the risk of malignancy. But in the recent guidelines, this has been removed and nobody is commenting, and it's not part of the thyroids.
It's a really important observation, and it's actually that was actually one of my tasks for reviewing for the 2009 and 2015 guidelines. So it turns out that vascularity is probably associated more with follicular patterned neoplasms. And when you look at the studies where vascularity was an independent risk factor in a multivariable analysis, so taking into account the other features, the only large cohorts where vascularity remained an independent predictor was in certain areas where follicular carcinoma accounted for more than 10% of the pathologies of thyroid cancer in that area. And currently, at least in the United States and many parts of the world where iodine supplementation now occurs, the prevalence of follicular cancer has decreased, and so it's less than 10%, and vascularity has not been shown to be an independent predictor for the papillary cancer types.
Okay.
And so that's why it's not used, because it falls out in those analyses.
So if we look in the ultrasound and there are no features that suggest malignancy, would it be safe to leave the nodules like that?
Yes.
So which nodules, I'd say, I can safely leave it?
Yeah, so I think that's one of the big advances in our use of ultrasound for risk stratification, is that whether you look at ACR TIRADS, EU TIRADS, K TIRADS, the British system, or the American Thyroid Association, every single risk stratification system has identified either a pure cyst as something that does not need to be biopsied for malignancy risk, or something called a spongiform or microcystic nodule, which is a nodule that has many small microcystic spaces in it. The risk of cancer is so low that there are no recommendations for FNA for risk of malignancy. And I think that's been shown very well in an Italian study where they had before the introduction of these risk stratification systems, they had biopsied all nodules over a centimeter based upon size alone. Okay. And then they retrospectively applied the risk stratification ultrasound systems. They actually did 4 of them, but what they found for all of those was that you actually biopsied only about 40 to 50% of the nodules that they had biopsied simply based upon size, because the others were either very, very low risk, or they were maybe slightly higher risk, but they didn't meet the FNA size cutoffs.
So you definitely met a lot of patients who has like sort of benign or very low or very low risk nodules, but they're really anxious. How do you address this patient anxiety? Would you reassure them, or sometimes you might need to go for an FNA for reassurance?
So it's a great question, because once you're told you have a lump, everyone's first their mind goes first to thinking, I have cancer. Yes. And I know as a patient myself, I see something on my skin. What is it? Do I have to see my dermatologist? So every patient comes to you with the idea that, could this be a cancer? Now, fortunately, if they've had an ultrasound, our patients can now read their ultrasound reports, so they can hopefully see that if it's a very low risk nodule, they've seen the radiologist report. But our job as a clinician is to better explain that to them. And I think, hear what their anxiety is about. So we have to listen and not just explain, because it could be someone's very anxious because someone in their family was just diagnosed with cancer, a different cancer. So we have to understand their anxiety so we can then address it, and we can explain the development of risk stratification systems and the large compendium of data we have that supports that spongiform nodules have a 1% or less risk of cancer. But I always think it's very important to listen, because even if a patient thinks it's cancer, patients have different reasons for thinking that. And so to understand what it is that has led that patient to that conclusion is very important for us to address their anxiety.
Excellent. This is an excellent way of addressing patients' anxiety. Then, as a clinician, you might see a patient who comes to you with let's say a suspicious thyroid nodule where you need to do FNA, or it's a low risk and you don't need to do FNA. So how would you follow those patients in a structured way? Those you did FNA, how often you should see them again? And those you didn't need to do again, how often you should do? How do you structure your follow-up?
Mm-hmm. So for patients who potentially don't need FNA, I first say, how did they get there? So I am one of the chairs for the new ATA 2026 guidelines, and one of the newer aspects of those guidelines is we no longer have a single cutoff for FNA. Okay. So if you have an isoechoic solid nodule, which would be ATA low suspicion or TIRADS 3, right now TIRAD says you biopsy at 2.5 centimeters, ATA says 1.5 centimeters. Yes. The new guidelines say you can biopsy between 1.5 and 2.5 centimeters, and you should biopsy over 2.5. There still is a cutoff, but it means that I, as a clinician, can sit down with you and say, you have a 1.7 centimeter nodule. Do you have risk factors for cancer? How anxious are you? It's a joint decision that we make about biopsy. So if we decide not to biopsy, and the nodule is in that range where we could potentially biopsy your nodule, we will then follow you based upon different ultrasound intervals, and the ultrasound intervals are determined by the baseline risk of malignancy. Excellent. But nodules grow slowly, so no one's doing an ultrasound in 6 or 12 months unless it's a very, very suspicious nodule, and that's a different category. Yeah. But the first ultrasound might be at 9 to 12 months or even 18 months. Okay. And then the recommendations for follow-up would be, if the nodule is the same size, you can then increase the interval. Yeah. But if the nodule grows, that's when you would intervene. And there are definitions of growth. On the other hand, if you biopsy a nodule and it's benign, there are also recommendations for how to follow it. And one of the other very important additions in the new guidelines is we no longer recommend repeat biopsy for growth. So it used to be, we said if a nodule grew, you would consider a repeat biopsy. The review of the literature has shown that once you have a benign biopsy, read by a good cytopathologist, the risk of cancer is 3% or less. And if you're trying to find that missed cancer, growth is not your discriminant. Instead, what you would be doing in your follow-up ultrasounds is looking to see if the nodule changes its ultrasound pattern. So does it go from a low suspicion isoechoic solid nodule to an intermediate suspicion? But if the nodule stays in the same level of risk on the risk stratification system, even if it grows, you do not have to repeat the biopsy.
Excellent. So it's basically a change in characteristics rather than size.
Exactly.
Excellent.
I would say with one exception.
Yes.
And that is the rare spongiform nodule that someone may have biopsied. You may not have biopsied, but someone else may have biopsied. And we know that spongiform nodules that have undergone biopsy can develop macrocalcifications.
Yes.
And so if that happens in that rare circumstance, we leave those alone.
Excellent, excellent. One last thing, and I think that would be my last question. As we said, the benign nodules or low-risk nodules, we can follow and we can leave them. Now, currently, there is a trend that even if you biopsy and you find a papillary thyroid cancer, in some cases you do just surveillance and follow-up. So, do you practice that, and how do you advise people to do?
Yeah, so you're talking about the concept of active surveillance for small papillary thyroid cancers. So the first thing is small. So initially small was less than 1 centimeter.
Yes.
Now small is being stretched up to less than 1.5 centimeters.
Okay.
So if you have either diagnosed a small nodule, that's papillary cancer, or better, it is highly suspicious on ultrasound and you have that discussion and you decide not to biopsy it, there are first certain features about the nodule that would allow you to consider active surveillance. So on ultrasound, the nodule needs to be confined within the thyroid. It shouldn't have any extrathyroidal extension, and its location is very important. So if that small cancer is in the posterior aspect of the thyroid, where the path of the recurrent laryngeal nerve is, we are less likely to offer active surveillance, because if the nodule were to grow and to become extrathyroidal, it could be challenging for the nerve. The other place is up by the trachea, so if it's really against the trachea, that also then becomes a ultrasound appearance of a nodule that's not a candidate for active surveillance. So against the trachea, posterior by the recurrent laryngeal nerve. The third thing is if there's extrathyroidal extension on ultrasound, not a candidate. And the fourth thing is if there are any abnormal cervical lymph nodes. So provided your nodule is confined to the thyroid, has surrounding normal tissue, has no abnormal lymph nodes, the nodule is a candidate for active surveillance. But then there's the patient, because the nodule lives in a patient. So what we know is that small papillary carcinomas are less likely to grow in individuals over the age of 50 to 60, depending upon which study you look at, and more potentially likely to grow or develop abnormal lymph nodes in younger patients. So it's a discussion with patients. And then the third thing we look at is the medical expertise to follow a patient. So if your patient is going to be far from an area where they can have frequent ultrasounds and have ultrasound expertise for follow-up to evaluate for abnormal lymph nodes or growth, then they probably are not a good candidate because of their access to medical care. So we look at the nodule, we look at the patient, and we look at the ability to follow it. And if they meet those criteria, they are very good candidates for active surveillance. And studies have shown that over a decade of follow-up, less than 5% of patients will either have significant growth or develop abnormal lymph nodes.
Excellent, excellent. Professor Susan, I always enjoy discussion with you, and we're always grateful for your attendance to our conference. One last thing, as long as we have a lot of young physicians and endocrinologists, what's your advice to practicing endocrinologists in our region?
About thyroid?
Thyroid, yes.
So I think that if you are going to practice, so first I would say endocrinology has become so complex. Look at all the exhibits that are in this room. You know, if you're a diabetologist, there's so much technology you need to use.
Yeah.
You know, if you're doing a metabolic bone, there's so many new medications that you need to be aware of. So, but if you are practicing thyroid, even if you are not performing your own thyroid ultrasounds, you have to be able to interpret ultrasound imaging and understand the pitfalls of ultrasound imaging. So I would say ideally, if it's feasible for you to have your own ultrasound machine and to become skilled in doing ultrasounds and ultrasound guided biopsies, that would be ideal. But I know that's not possible in many areas because of radiology and politics and insurance.
Yes.
So then you need to not just read reports, but you need to be able to look at the images and speak to your radiologist so you can make sure that there is accurate classification of thyroid nodules. Because when caring for patients with thyroid nodules and then subsequently for thyroid cancer, ultrasound is one of the major modalities we use, so you have to become familiar with it and skilled at least in looking at the images.
Finally, I would like to thank you very much for being with us, and it's always a pleasure to be with you.
Well, I want to thank you very much. It's always a pleasure to be with you. It's always a pleasure to see you again, to do ultrasound courses with you. And it's wonderful to be here, and hopefully again.
Thank you. Hopefully,
Thank you.
inshallah. 2027? And
2027,
before that,
many years, and hopefully many years of health.
inshallah. Thank you. Thank you very
Thank you very much.